This meeting is being publicly streamed.
I'm Shanmukh Srinivas, General Medicine first year PG. Going to start General Club this week, and the topic is Abelacimab versus Rivaroxaban in patients with atrial fibrillation. Yeah, Abelacimab versus Rivaroxaban in patients with atrial fibrillation. Sustained arrhythmias and 50 million affected globally every year. And atrial fibrillation raises the risk of stroke to 5 times, and so anticoagulation is key for prevention of stroke here. So currently we have three therapies for prevention of stroke in atrial fibrillation. They are vitamin K antagonist like warfarin and direct acting oral anticoagulants like rivaroxaban or apixaban, which are preferred. And this trials tells about Abelacimab, which is factor 11A inhibitor. Yeah. Um, Here, DOACs are preferred compared to vitamin K antags because vitamin K antags like warfarin raises the risk of intracranial bleeding, while DOACs like rivaroxaban and all increases the risk of gastrointestinal bleeding. So there is any need of safer anticoagulants in atrial fibrillation. Yeah, here we are considering factor 11A inhibitors. Why are we considering factor 11 inhibitors here? The reason is they only target thrombosis without impairing hemostasis. And abelacimab, the monoclonal antibodies inhibiting factor 11, which has potential to reduce, which has potential to reduce bleeding risks, just like unlike warfarin or vitamin K antags, which increases intracranial bleed, and DOACs, which increases gastrointestinal bleed. Here, there is no such risk of bleeding. As we see in image, abelacimab, which is factor 11A inhibitor, and we also considering here rivaroxaban, which is factor 10A inhibitor. Background: factor 11A biology. Factor 11A is essential for thrombosis, but not essential for hemostasis. So there is reduced risk of bleeding. Genetic deficiency. We understood this by learning from genetically deficient persons of factor 11 or 11A. Abelacimab. Mechanism. It acts two ways. And first way is it inhibit activation of factor 11 into factor 11A activated factor, and it also inhibit activated factor 11A. These are two mechanisms by which abelacimab acts. Methodology or study design is here they concluded, they published phase 2 trial, which is multination randomized trial to reduce bias, and actively controlled trial. They mean they are giving active therapy, and they are uh, comparing it with the existing standard therapy like DOACs, and the therapy is partially blind. Here, around 1250 people are taken into consideration into 1 is to 1 is to 1 ratio, equal ratio to Abelacimab, which is factor 11A inhibitor, and rivaroxaban, which is standard DOAC given. In Abelacimab, they are giving two doses, 150 mg and 90 mg. Here, 150 and 90 mg doses, these doses are given in blinded way, while the rivaroxaban 20 mg is given as open label. And this is drawback of study which is given in later part of the PPT. That's why it is partially blinded study. Procedure of study, randomization and dosing. Yeah, and monthly subcutaneous Abelacimab was given versus daily oral rivaroxaban in 20 mg dose. The follow-up. Uh, Follow-up is done by phone call on every 8th day and in-person visit every monthly and laboratory visits also every third monthly. And pharmacodynamics. After administering factor 11A inhibitors, they are measuring free factor 11 levels, and it shows near complete suppression of factor 11A after administering Abelacimab. And an independent committee blinded to assess treatment associated bleeding or stroke events. Inclusion, sorry, inclusion criteria. Here, the key eligibility is age more than 55 years with atrial fibrillation or flutter. SHA2 has score more than 4 or more than more than 4 or 3 when the patient has additional risk like creating clearance less than 50 ml per minute, or they have history of usage of antiplatelet drugs. And exclusion criteria. High bleeding risk, recent stroke, and severe renally or hepatic impaired persons are excluded from this study. This is characteristics of patients at baseline. The median age group is 74, 75 year, and creating clearance less than 50 for uh, is for 20%, approximately 20% in all the three groups, and pattern of afibrillation also given as follows. And charts 2 as score as follows, and has 2 has blood score as given. Yeah. And the primary endpoint of the trial was any major or clinically relevant non-major bleed, or primary or exploratory endpoints were any major bleed or any bleed, stroke, embolism, death, or so. And statistical analysis, around 1287 patients were enrolled. The trial got terminated early than the designated date due to significant bleeding reduction with Abelacimab. Here, the data about endpoints were given in this table. And safety regarding the trial, there is an independent committee which got blinded and which monitoring the safety of the trial. And the serious events are 39% in Rivaroxaban taking people and 36.2% in Abelacimab 150 mg. Well, it's error. Last one is it's 90 mg. Abelacimab. Trial stopped early due to clear bleeding benefit with Abelacimab. Outcomes. Primary outcome. Bleeding events with Abelacimab 150 mg subcutaneous per month, like 3.2 events per 100% years. And for 90 mg, it's 2.6 events per 100% years. And for Rivaroxaban 20, it's 8.4 events per 100% years. And hazard ratios, when compared with Rivaroxaban, the Abelacimab 150 mg holds 0.38 hazard ratio, while 0.31 is for Abelacimab 90 mg with p-value less than 0.001. Secondary outcome, major bleed and gastrointestinal bleed. Uh, the major bleeding percentage is around 1.2 to 1.9 in Abelacimab group, while 7.2% in Rivaroxaban. While GI bleed, which is major concern in Rivaroxaban using people, it is 4.2, while it's 0.5% in Abelacimab using group. Results where efficacy safety balance is taken. Ischemic stroke is numerically high with Abelacimab group, but statistical significance is not there. Net clinical outcome hazard ratio is 0.55 to 0.58 favoring Abelacimab. Conclusion: Abelacimab reduces reduced bleeding by 60 to 70% when compared to Rivaroxaban. The sustained factor is suppression for more than 97% in 90 mg group. Open label Rivaroxaban and small sample size around 1287 people, predominantly white cohort like European and Asian people are participated in the trial. These are limitations of trial. And the next step, this is TIMI-71 trial we are discussing, but the next step is TIMI-76 trial. TIMI-71 trial we learn is all phase 2 trial, but the next step here they are taking TIMI-76 is phase 3 trial, which is ongoing, efficacy in the stroke prevention of the drug we are discussing. Thank you. Thank you, one and all.
Yeah, hi Shanmugh. Few questions for you.
Sir, sir.
So can you tell me what is Chadwick score and its components?
Hello, sir.
Yeah, Shanmugh.
Yes, sir.
Yeah, I'm
Sir, am I
asking
audible? Yeah, yes,
Chadwick
sir.
score.
Uh, Congestive heart failure for C, hypertension for H. A2 stands for age more than 75, score is 2. Age more than 65 to 75, the score is 1. D for diabetes. S for previous stroke history. And V for vascular disease, or Chadwick score.
One more is done. What is SC in that?
One.
Oh, so SC is gender, na? SC means gender, that is sex category. Okay, that is female is score 1.
Yes, sir.
So how much should be the Chadwick score for starting anticoagulation in AF patients?
Sir, it should be more than equal to 2, sir.
Yeah, okay, correct. And what is Hasbled score?
Sir, Hasbit score is score used to assess the risk of bleeding after giving anticoagulants in atrial fibrillation patients, sir. And H stands for just a minute. Hasbit.
You're not supposed to see an answer. Huh?
No, 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 sir. Yeah, I just forgot them, sir.
Yeah, no problem. Even if you don't know, no problem, Shanok. But just read it later, okay? Chadwick score, Hasbled
Yeah,
score, you should be able to answer.
sure, sir.
It is both
Sure,
important for
sir.
your theory as well as for practicals, as well as for your clinical practice also when you're in
Yes,
rounds
sir.
seeing patients and all.
Yes, sir.
To assess the
Yes, sir.
bleeding risk of a patient. Okay. Yeah. And can you tell what is hazard ratio? You mentioned a lot of places hazard ratio is there.
Sir, hazard ratio is relative risk when compared to existing treatments, sir. When it's equal to 1, risk is just like plateau. It's not increased or not decreased. It's like neutral risk, sir. When it's more than 1, the risk is more, and less than 1, hazard ratio indicates less risk, sir.
Okay. So in your study, how much was your hazard ratio for Abelacimab? How much you got that?
It's less than 1, sir. Around uh,
Okay.
0.55, sir.
Okay. So you mean
0.55 to
that Abelacimab
0.57.
is better than Rivaroxaban in terms of the hazard thing,
It's,
basically. So
yes,
hazards
sir.
is less. Okay.
Yes, sir.
And you said it is phase 2 clinical trial, no?
Yes, sir.
Okay. You know, do you know what are the phases of clinical trials?
Yes, sir. There are 4 phases of clinical trials, sir. Phase 1, 2, 3, and 4, sir. Phase 1 is to assess safety. Phase 2 is to assess the working or the mechanism of action of the drug, while phase 3 is to compare the existing drug with to show improvement of new drug with the existing drug, sir. Phase 4 is post market trials, sir.
So I think you have confused here a little bit. Okay. So phase 1 is basically to see the dose. Okay. So dosage safety, which you want to assess, we'll use phase 1 trial, which
Yes,
is
sir.
done in a lesser population. Usually it is below 100, 20 to 100. Okay.
Yes, sir.
Then after you, once the safest dose you know in that, that is the maximum tolerated dose when you know about that, then you go to the phase 2 to see
Yes,
whether there is any efficacy. How is the efficacy of that? So in phase 1, you will not look at the efficacy at all. You will only looking at the side effects.
yes, sir.
In phase 2, you will see that in that maximum tolerated dose, whether there is any efficacy is there or not. That is phase 2. Usually that will be 100 to 300 population.
Yes, sir.
Okay. And then after you see that in that dose there is efficacy is there, then you go to the phase 3 to look at a larger population. So you want to do a large scale or confirm it. It's like confirmation of the phase 2 in a larger population. Usually population will be around 3,000, 300 to 3,000 population. You do that.
Yes, sir.
And after doing that, phase 4 is the post-marketing surveillance to see how it goes in the common people, general populations.
Yes, sir.
Okay, so phase 2 is over. Phase 3, they are planning, you said. No, okay.
Yes.
So overall, what do you say? Abelacimab is better or Rivaroxaban is better?
In this study, it shows Abelacimab is better compared to existing ones like Rivorixaban, sir. But there is more need for further studies, sir, to assess the risk of stroke.
Okay, I think the sample size was slightly less here in this study.
Around
So
1200 AP, sir.
it was phase two trial only. So they just wanted to see that is whether it is effective or not. Maybe the phase three data will give us a better result, better picture of it, whether it will be useful or not in clinical practices.
Yes, sir.
So you know what are the other NOACs? Can you name them other than Rivaroxaban? What are the NOACs?
Yes, sir. Direct thrombin inhibitors like dabigatran, sir.
Okay.
Factor 10 inhibitors like rivorixaban, apixaban, sir.
You know the dosages of them?
Yes, sir. Apixaban 5 mg, sir. Uh, rivorixaban is 20 mg, while dabigatran is 150 mg, sir.
No, but it exactly is not like that. See, dosages vary based on the clinical indication.
Yes, sir.
So for patient with pulmonary embolism or a DVT, that means evidence of where you have to treat the thromboembolism, no? The dosage is different. For atrial fibrillation, the dose is different. And for prevention, suppose you want to give only for a DVT prophylaxis, the dosage will
Yes, sir.
vary. Okay.
Yes, sir.
We are still in your first year, it's fine, no problem, but just go and read about them. Okay, you need to be aware of the dosages of all the NOACs,
Yes,
Rivaroxaban
sir.
dosages, apixaban dosage, okay,
Yes, sir.
edoxaban dosages you will be aware of, dabigatran dose in all three conditions for the treatment, prophylaxis and atrial fibrillation, all three have a different dosage.
Yes, sir.
So whenever you get time, you read about that. In our next class we shall discuss about that also, NOACs.
Yes, sir.
Okay. Whenever you're doing any drugs, no, and now you're in clinical position like post graduation you're doing. So also try
Yes,
make an habit of reading trials, clinical trials also. So now
yes,
how
sir.
you have presented here are clinical trials. Similarly, all those drugs before coming into guidelines, there was a lot of study which was done on those drugs as well. So
Yes,
some
sir.
landmark trials which made the drug into the guidelines, that trials you are supposed to know.
Yes, sir.
Especially for a general medicine residents, NOVAX is the one where examiners tends to ask them questions of clinical trials.
Yes, sir.
So today you go and read about all the clinical trials, landmark trials on the NOACs, that their dosages and how
Yes,
they
sir.
okay. Okay. Overall you presented well. Okay, it was a very good presentation for your first time. But you can still improve day by day. Try to present more and more cases and journals.
Yes.
Okay.
Sure, sir. Thank you, sir.
Okay. Anybody has any questions or doubts, they can ask me. Okay, I think we can end our session here. Okay.
Yes, sir. Thank you, sir.
So you want to ask anything, sir, Dr. Neeraj? He left.